He's a former assistant professor of anesthesia at the University of Pennsylvania, director of the chronic pain management at University of Texas. He's going to talk about neuromodulation, evolution, the past, present, and the future of the spinal cord stimulation. Dr. Mustafa is highly experienced in this field. Let us know more and more about neuromodulation from Dr. Ahmed Mustafa. Welcome, Dr. Mustafa.
Thanks so much, Ahmed. First, I would like to thank you, everyone, for having me over here and get to know everyone. So I'm talking today about the neuromodulations and the history about the spinal cord stimulator. So basically, the neuromodulations is it's just alteration of the nerve pathway, not to treat pain, just
Dr.
managing
Mustafa,
the pain.
can you share your screen, please?
Did I do? I am not able, I don't know how I can do that here. Just, do you have access to that? I think. Are you able to hear me, right?
We hear you clearly, but the screen is not
shared.
available.
Okay.
Yes.
So we'll do, okay. So we talk about the neuromodulation, and as I mentioned, that the neuromodulation is not treating the pain, is managing that way. It's just a way of masking the pain by alternating the nerve signal, either going from infratentorial to supratentorial or vice versa, or using a change in the chemicals or the neurotransmitters around the nerve bundle. So I want to just remind everyone about the Leo Tolstoy, when he talked about if you feel pain, you are alive. But if you feel other people's pain, you are a human being. So try as a pain physician just to understand how is the patient feeling about his pain and respecting that. So in 2017, Mark Hantoon asked me to write a chapter about the peripheral nerve stimulation. And he said, before you write these chapters, I want to mention history about the spinal cord stimulation, peripheral nerve stimulation, and the theory behind the neuromodulation and using electricity. So I dig at that time, I found these papers been published and showing that the ancient Egyptian using a catfish or Nile catfish as a method for managing joint pain, migraine, epilepsy, melancholy. And actually, this paper found in Saqqara. And that's telling us using electricity for managing pain is not something new, but it's been in old. And also in Hippocrates, in his book as a father of medicine, he bought these bladders and as an ancient Greek called fish bladder, and using a torpedo fish and Nile catfish for headaches. So it's basically they get that fish in and put this fish on the top of the head and actually giving electrical shock and giving about 4 hours of pain relief from headaches as an latency. But they've been using that. And that's what I found when I wrote that chapter back in 2017. And everything changed when Malzak and Wall wrote the papers in 1965 in the Science magazines and talk about the gate theory. And that's when everything changed back in 1965. I'm pretty sure everyone aware of the gate theory, but basically there is two aspects on that one. One is a scientific, and the other one, how are you going to tell your patient if they ask you what did the neuromodulation, what the spinal cord stimulator will do for me? How does that work? So if we look to the, as we know that there is a nerve fiber, we have a small and large nerve fiber, we have A delta, A beta, and the C fibers. And all of a sudden, the latency comes from the C fiber that's giving a chronicity of the pain. Everyone has an acute pain, subacute pain, chronic pain. And the period between acute pain and chronic pain is a method called chronification. How is the pain transformed from acute form to a chronic form? And that's what we're talking about, the chronic form, which is transmitted by C fibers. So the gate theory is basically, if you are stimulate the A delta or A beta fibers, it's basically you are not opening the gate to send a chronic signal to the brain. But if you stimulate the small fibers, basically you open up the gate, and then now you start to feel the chronic pain. So what they try to prove, if we are able in a patient that has a chronic pain or chronification developed, and the chronic pain developed due to neuropathic pathway, then if we are able to stimulate the big fibers, the A delta or A beta fibers, then we're actually able to close that gate and prevent sending a signal from a small sensory fibers, which is a C fiber. How you make it easy to understand that? Patient come to me and say, hey, listen, you're telling me about the spinal cord stimulator. How does that work? I'm not going to sit down and explain the gate theory to him. So what usually I tell the patient, let's say that you like tea or Coke or something like that. You put some sugar on the tea and try to drink that. How do you taste? Oh, yeah, taste sugary. So, okay. How about eating some sweeter, like an Oreo, or getting baklava or something like that, much sweeter? And then you start to take a sip of the tea. Did you still taste the sugar in the tea? They said, no, we cannot taste it. But why? We already know that there is a sugar in the tea, and you take a sip right now, but you don't taste it. And 2-3 minutes later, or you wash your mouth and then take a sip again from the tea, you can taste the sugar, because the brain cannot see two sugar in the same time. It's shut down the gate for one, but open up the gate for the other one. And that's basically how the spinal cord works, theoretically, based on the gate theory. I'm going to move on here, and we can find that Norman, back in 1967, is the first one in Wisconsin able to put a stimulating lead in epidural space safely without a complication, and able to connect that. This lead's actually coming out of the patient back, and he have to take his patient to the lab to connect these two electrodes to the big humongous machines which deliver the impulses or the electricity to that electrode. And he was able actually to prove that he was able to create a good pain relief. In 1968, so this is Medtronic was able to commercial the first spinal cord stimulators. But again, this is not implantable device, is placed on the epidural space, but the lead has an antenna coming out of the back of the patient, and the patient need to go to the hospital to connect this one to the battery that give him a stimulation, might be once a day, once every 2 days. From 1968 up to 1981, the same things happen, except now we have in 1981, they developed the first implantable IPG or implantable pulse generator for spinal cord. Let me talk about the anatomy of the spinal cord device. We have leads and we have IPG. And I want you to remember that the IPG is the brain of the spinal cord stimulator. We're not going to talk about the peripheral nervous stimulation on that lectures. We're going to just talk about the spinal cord stimulator. So remember that the IPG, or what we call implantable pulse generator, is the brain of the spinal cord stimulator. We have two types of lead. We have a pedal leads and we have percutaneous lead. As a pain physician, we never use pedal lead because this is done by neurosurgeon or spine surgeon who have to do a laminectomy first and then put these two leads underneath the top of the ligamentum flavum, and then they put these leads and suture that on the dura. So if you get the chance to have a patient that comes to you in your clinic and tell you, I have a leads in place and really is not doing anything for me and it's bothering me, I want to take him out. So be very careful to don't pull that lead, because if you pull this lead, you actually strip off the dura. You're going to have a humongous lead. So be careful to know what type of leads they have. Pedal lead is sutures to the epidural space, to the dura, and be careful, don't touch them. If the patient really need to take them off, send them back to the spine surgeon to take them off. Percutaneous lead, we will never suture that to the dura, but we might have an anchor. Be aware of that as well. Now, again, the IBG, as you see over here, the epidural lead percutaneous, we have a different type of epidural leads. I'm sorry, the percutaneous lead, we have 16 stimulating dots or contact, and also we have 8. Most of the time, people, they use 8. Some Infonian use 16 stimulating leads. Where are you going to place this one? So usually the patient comes to you again. I want the spinal cord stimulator. Where are you going to place that one? I'm not going to tell this patient that I'm going to put this lead underneath the ligamentum flavum and behind the dura in a place called epidural. Now, most of the people now, they are aware of the epidurals with the pregnancy and the pregnant woman when she get delivered. So I said, the lady that had epidurals with the pregnancy, we're going to do the same thing. But in epidural, usually in a pregnant woman, usually we run some local anesthetic to deliver, or narcotics to deliver some analgesia to this patient. You are not going to run any medications. Basically, we're going to run some electricity to control your pain. And as you can see over here, you can see the electrodes placed ventral to the ligamentum flavum, posterior to the dura. Here, I don't think so. This is important right now until you are really planting that and you would like to know where you're going to put the tip of the stimulating lead. We have different places. This is one of the distribution that I use, but sometimes we divide the spinal cord to a segment 1, segment 2, segment 3, segment 4. And based on where is the pain distribution, either referred pain or radicular pain, then you can decide where I want to stimulate the spinal cord. Again, so what are we stimulating? Are we stimulating the spinal cord? No, we're stimulating only the dorsal component of the spinal cord, which is the dorsal column, dorsal root, or dorsal cord. These are the 3 things that we're stimulating or you are aiming for. We have 2 different places. You have to understand that there is an anatomical midline and we have a physiological midline. So most of the time, if you use a different conventional technique, then you have to understand where you're going to place your lead. Not in the midline. We're looking for the physiological midline. You might see the stimulating catheters in halfway, or what we call zone 1, which is immediately between the medial and lateral aspect of the spinous process. And you must say, yes, I'm perfectly centered here. But as a matter of fact, the spinal cord is shifted, and now the anatomical midline not related to the bony midline. So how does the spinal cord work? We talk about the gate theory, basically, but I quote this one from one of the articles we published in 2018, and he stated that mechanism of the spinal cord stimulation for the treatment of pain is still in the dark after 50 years. And that's true. Up till now, we don't know how does the spinal cord work. Even the gate theory, most of the people right now, they said that's not the truth. That's actually is multifactorial. So they divided that to what we call supratentorial, infratentorial, and neurochemical changes. Some people, they call it supraspinal effect, spinal effect, and neurochemical changes. Some people, they say there's a supraspinal and segmental and neurochemical. Whatever you call it, whatever you name it, we know that something happen or changes on the brain, something happen and change in the spinal cord, and the chemical changes in both sides. So if you talk about the supratentorial or supraspinous effect of the spinal cord stimulator, this is we're able to do that in a human being. We use the functional MRIs, we use the PET scan. So in the functional MRIs with the people, they have stimulation, and we saw them before and after, they found that there is an activation in primary and secondary sensory motors. Also, posterior insular cortex, changes in the functional connectivity between sensory and limbic area. And all of us, we know that has a huge impact on the sensory affective of the patients in terms of emotional, psychological, psychosocial. All this stuff has been affected by that. In terms of PET scan, we found that increased blood flow going to the thalamus, bilateral parietal association area, and anterior cingulate cortex and prefrontal area. Again, no one knows which one is really segmental changes transmitted that all the way up to supratentorial or vice versa. So if you look here in the segmental or the spinal cord itself, all the study come from animal, because we are not able to study that in human. So from the animal study using electrophysiological study, we found that attenuation of nociceptive reflexes, sympathetic reflexes, and reduction in H reflex or Hoffman reflex, and component of somatosensory evoked potential. What that means? Sympathetic reflexes, that's partial sympathectomy that lead to a vasodilation. And also in nociceptive reflexes that lead to analgesia. So basically now people they talk what how is the spinal cord is effective in peripheral vascular disease, peripheral arterial disease, venous ulcers. Yes, it can be effective. You can see over here in neurochemical changes or activation, we can see antidormic release of calcitonin gene-related peptide or CGRP, and that leads to release of the nitric oxide, which is very helpful for as a vasodilators. We talk about the trap V1 receptor activation, and to understand how there is a trap V1, trap V2, 3, 4, 5, up to 8. But what that means with the capsaicin? Capsaicin is a hot pepper, and I tell my patient that if you put hot peppers on your tongue, what do you feel? I feel hot. And instead, if I took a temperature probe and I put it in your mouth, do you think it's gonna be a fever? It's probably yeah, a little bit, but not that much. Again, if you put a menthol in your mouth and you see like, wow, it's very cold. I put the temperature probe in your mouth and I said, it's a normal temperature. Yes, it's going to be normal temperature, but the stimulation process give you the sensation of cold or give you the sensation of hotness. Capsaicin, by stimulating the trap PV1, induce vasodilation by release nitric, and also induce inflammatory process. That's why you see the burning sensation with this one. And this one, when you stimulate that with the spinal cord, basically on the neurochemically changes, lead to a vasodilation, which is very helpful in patients with intractable angina that's non-operable. People they have a peripheral vascular disease with unhealed ulcers with a special criteria that can be helpful using the spinal cord stimulator. Increased GABA, acetylcholine, serotonin, all these chemicals when increased induce analgesia, as we know that. Again, spinal cord stimulation implantation, if you look nationwide, is 50,000 annually people implanted these spinal cord stimulators. What did that mean? If you see a 50,000 spinal cord stimulator implanted annually, that's telling you that how is effective the therapy. Number two, minimal complication side effect happen from that interventional. Number two is easy performing because most of the people now they are able to do the interventional technique with some safety. Here again, what is the indication of a spinal cord stimulator? Again, neuropathic versus biomechanical pain generator. Remember that I believe it was last month. We have a morning round meeting for orthopedic surgeon morning round, and then we are attending a couple of pain physicians, most of the spine surgeon, and then we have a very complicated patient with multiple back surgery and just a mess. And then the question was, how you make a decision? Are you planning this patient has laminectomy, spinal fusion, still complaining of pain? They given tons of narcotics, no response. Now this meeting just what should we do with this one? And the question is, if this is pain of that patient, it's a neuropathic pain, or this is a biomechanical pain, and that's what make a decisions. Is good for this patient to have a spinal cord stimulator versus placing an intrathecal pump. So what I believe is, and most of the pain physician literature supporting with some quote here, I'm going to talk about that later, is if the patient has a biomechanical pain generator, like let's say some hardware failure and there's a movement and every patient is moved causing pain, you think the spinal cord stimulator worked? Most probably not. This hardware need to come out and put the good hardware. If this patient has a facet mediated pain, do you want to do a spinal cord stimulator? Most probably not. With some concern about that because the new study showing that improvement in pain condition with the people they have a biomechanical problem. But usually, before you make a decision if you want to put a spinal cord stimulator or not, make sure that if this is really neuropathic pain or biomechanical pain. If a biomechanical pain generator, try to figure out how can you fix it first. before you move on to a neuropathic pain. My recommendation on that particular part, if I see a biomechanical pain generator not associated with any neuropathic pain, I put intrathecal pump. So what is the indication for neuropathic pain for spinal cord stimulation? Number one, which is the most common indication, is filled back surgery syndrome with the radicular symptoms. Number two, CRPS, either type 1 or type 2. Both of them work really nicely. DB or diabetic, painful diabetic peripheral neuropathy. It's approved recently in the United States. We're using a lot right now. Phantom limb pain, refractory angina pectoris, peripheral ischemic limb pain. One of the things that I was mentioned early, if the patient has a peripheral vascular disease and the patient has an ulcer, is a completely different from a diabetic patient has an ulcer. If a diabetic patient with a severe peripheral neuropathy come to you for implant with this ulcer, I'm not going to put stimulator. I need this ulcer completely healed, skin is closed before I put the stimulator for the sake of the infection. But for vascular, if the patient has a non-infectious ulcer due to ischemia, within 2-4 centimeters, I can go ahead and put the spinal cord stimulator. And bigger than that, I'm worried about secondary infection, so I usually try to avoid that. Lumbar or cervical radiculopathy, if the patient is high risk or high risk patient with a comorbidity, the surgeon doesn't want to take the patient for surgical intervention. And as I mentioned, axial pain. Is this a spinal cord stimulator can work in axial pain? There is, right now, I'm not convinced. Still, there is a couple of studies been published recently showing that, yes, neuromodulation, spinal cord stimulator can work for axial pain. You can see if the patient has spinal cord stimulator and come for lower back pain, mainly axial, just referred pain, no radicular symptoms. I try to adjust the spinal cord stimulator, try to cover that. Most of the time I failed. Then I have to do MPP and then RFA. Patient selection. It's very important for your patient selectivity to use that therapy and get an outcome, really good outcome from that by patient selection. You know that here in the United States, patient has filled back surgery syndrome, radiculopathy, just get them in for a try. This is not the point. The point is really this patient going to benefit from that therapy or not? So selecting the patients is very important. Number one, underlying disease and comorbidity. Make sure that the patient is optimized from diabetes. Make sure that the blood sugars or A1C will be less than 8. Some people, they consider 10. If this patient smoker, make sure that is not, stop smoking for at least 2 months before or 1 month before the surgery. Also, the psychosocial factor, the family support is very important. I remember that, especially financial. I remember I had a patient, he's a tractor, he's just cut the grass and mowing the grass. And I did spinal cord stimulator for that patient, implanted. And 2 weeks later, I got a call from the ER saying your patient is here and there is a collection on the bucket for the generator. So I came to the ER, do ultrasound, find the pocket, put the needle in, aspirate, pure pus coming out from the pocket. I asked him, what did you do? He said that, I never seen this patient, by the way. I did the surgery, I never seen again. What's going on? Why didn't he come to the clinic? He told me that he has no time, he needs to generate money. So he had the surgery. Next day, he was on the tractor in the field, on the grass, cutting grass. So, and even he doesn't want to have surgery because he has a party and he needs to go to the party because that happens annually. Anyway, long story short, we need to sign a consent for specific things. But if you don't select your patient, the implant that you do it, you're going to take it next week. So it's a family support is very important around that patient that's going to have the spinal cord stimulator. Psychological evaluation. Some people, they have major depressive disorder, type B personality disorder, manic, like bipolar. I want the device today. Next morning, I said, oh no, the device doesn't work, take it out. So this is a kind of, you have to select your patient to reveal or persist. Successful trial is very important to do the trials, and if the patient has the most important 3 components in successful trial. Number one, 50% pain relief. Usually my cutoff is 80% of pain relief. Number 2 is improved quality of life. Number 3, the daily activity improved. If the patient take narcotics, then the amount of narcotic used per day is dropped by 50%. Complications from placing the equipment. Overall, spinal cord stimulator is benign, safe procedure. Never been reported a death because of the spinal cord stimulator in the recent year. But equipment failure is very, I mean, I don't say common, but that can happen. Disengagement or dislodgement or migration of the leads is possible. Nowadays, we have the anchor. We can put the anchor nicely, put some strength loop. That will decrease the incidence of migration. Lead fractures, what they mean by lead fractures, some people, they don't understand exactly what the lead fracture is. Remember that these leads has a stimulating dots or contact. Each contact run a specific wire inside the plastic catheter. So if you bend it too much or the patient has multiple trauma or hit that fine small wire that's run in the catheter can fracture or break, and then the signal is not going to go to the stimulating dots. And I have a patient very recently, I believe a couple of months ago, he had the spinal cord stimulator for almost 3-4 months, and he came back, that's the pain's coming back, check the lead, and then we have a fracture lead, asked him about trauma. He said that he was in the field and hit by cab, and he fall, and that we think that trauma that's having can lead to that problem. Connector problems, very less common. I never see it. You have a good screwdriver, you just put it in tight, make sure tug on it, and just make sure that's not dislodging. Pain around the IPG is very common. So the bucket that you placed, make sure that when you do the bucket, you might see a cutaneous nerve, right? Do not cauterize that. Try to push it away. Don't cut it. But if you cut that one, you might develop a little bit of neuroma, entrapment that can happen, and that can cause a IPG pain or at the bucket side. MRI, now most of the IPGs is compatible with the MRI. So if the patient is a very old guy, most probably, I don't care if it's MRI compatible or not, but if young population, I make sure that that's IPG is MRI compatible because this patient might need MRI in his future. Surgical intervention can have a side effect, as you know that. The infection, bleeding, weakness, all these possibility from interventionally. So be careful in the, maybe with next future, inshallah, near future, so we might do a workshop how technically you can do that in a short period of time and don't expose the tissue for infection. I'm going to show you here how we place this one. It's very simple, very straightforward. On the left-hand side here, you can see the thoracic lead, lower thoracic seat. You can see the last strap. We put this one between T8, T9. That's a standard for lower back. And you can see the lateral. As we mentioned, that was stimulating the posterior component of the spinal cord, mainly the dorsal column. And you can see over here in the second image, the lateral view. And you have to make sure that the hole leads behind the foramen. This is, I don't know if you see my cursor, but this is the foramen here. This is the anterior part of the epidural. This is the posterior part of the epidural. And then your lead need to be in the posterior component of the epidural. Here on the cervical, you can see the first strip here. This is cervical area. And then I put them into C2, C1 right here, based again, where is the pain, where is the radicular symptoms will be. Make sure that immediately after the J here on the spinous process, we call it the J. That's the end of the spinous process and beginning of the epidural space, and you can see the lead placed posteriorly. I'm going to tell you something just a little bit different for how to use the spinal cord. This is one of my cases. This is a young lady. She had an accident back in 2007 or 9. I don't remember exactly, in Philadelphia, train crash. And she's been suffering for years for leg pain. And the plan for her to place a DRG. So unfortunately, my rep for DRG was not available. So I said, okay, let me do something different. I talked to the rep from a different company. I said, I'm going to put the spinal cord stimulators in a different way to stimulate the DRG. And this is a high frequency type. So I was able to do that and actually reported to the community here, and everyone liked the idea and started people doing that. I placed the needle upside down here. I was able to access the epidural space on the left side. On the right side, there's a video, but I tried to run it, doesn't work. There you go. And you can see the lead is coming down. You can see the lead, and from the needle, I put the lead here down. And I want everyone to remember that the spinal cord end in L1. So if you want to stimulate the dorsal column, you're not going to put the stimulating link below L1 because there is no dorsal column after that. So here I'm stimulating the DRG on a peripheral or spinal nerve. And did work very well. I put one down, I put one up, and it's called a technique developed called the cross-cross technique to decrease the incisional side. I can talk about that in a workshop later, but I want to give you a different way you can use a spinal cord stimulator, not only stimulating the dorsal root, but you can actually a dorsal column, but you can stimulate the DRG. And since this is a high frequency, I was able to go all the way down to the DRG stimulation without stimulating the motor nerve. I'm sorry, let me go to the next one. This is also very interesting case. This patient came to me with T12, L1 fusion all the way down. And I looked to the MRIs, I looked to the X-rays, no way I can put my needle in epidural space to get the stimulating electrodes to in a proper position. So I talked to her regarding, again, the retrograde technique, and I was able on the left-hand side, putting the needle in T1, T2 epidural space. And I was able to actually drop the electrodes from the top down. Here you can see the electrodes coming down from up down. And then here you can see the fusion, and you can see the tip of the load. If you see the T12, 11, 10, between 9 and 10 when I started, and then I put the lead all the way up, and this is a lateral view of that lead. It's placed posteriorly. Do you remember when I talked to you about the IBG is the generators or the brain of the spinal cord stimulator? Here you go. So as you mentioned that, all what we mentioned right now to placing spinal cord stimulators, anyone can do that. Anyone can put an epidural space. No big deals. The only things here is the waveform. What are we delivering to the spinal cord or the dorsal column? So traditionally, until 2015, we use only single stimulation called tonic stimulation or conventional spinal cord stimulator, which give you about 50 hertz. And that's how it's on the left-hand side. You can see give you pulse, pause, pulse, pause, pulse, pause, and then give you what we call the paresthesia technique. The patient feel buzzing, tingling sensation. And then in 2015, when first wave came on, give you that high frequency, just boom, 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 boom on buzz, and boom, boom, boom on buzz. And this is about 50 hertz for 40 bursts per second. That was like amazing, and that we're gonna do that. Less paresthesia. Patient does not notice that frequently, and then all of a sudden 2016 came in, and then Nevro came up with a high frequency that we can 10,000 hertz or 10K hertz can be delivered continuously to the spinal cord. The beauty of that, when I did study some on physiology, they found that every time you go up with the frequency, you will be able to stimulate the sensory and omit the motor. And when we do stimulations, like radio frequency ablation, as we mentioned in the hip articular branches RFA, we do a sensory stimulation, and then we do a motor stimulation. If you see the previous slide saying that at 50 hertz, I will stimulate the sensory, and 2 hertz, I will stimulate the motor. So every time you go down, you stimulate motor. Every time you go with the frequency up, you omit the motor, but still can stimulate the sensory. Why would not every single company know that from physiology or physics? I'm sorry, am I saying physiology? Physics. So they know that the problem or the challenge that they're facing is to deliver a 10,000 hertz in more than that, 50,000 K or 500,000, 500K or 500,000 hertz require humongous amount of energy. You can turn your battery on, next day, not next day, 3-4 stimulation, the battery is out. Then you have to sit down on the battery charging that. So this is the main challenge. That's why Nevro came in 2016 with that battery that can hold charging for about a couple days with a 10K or 10,000 hertz. That's what give us to the next slide is the what is the future? So now I see the technology is advancing very fast and quick. We are able by Saluta that developing another battery that has what we call all that what you see right now in the market is an open loop. That means there is no communications. Let me explain that in detail. Basically, when you put the stimulating electrode in epidural space, the posterior to that electrode is a ligamentum flavum. Anterior to that electrode is a dura. Then you have subdura space, and then you have the arachnoid, and then CSF and the spinal cord. That is not a static, it's a dynamic. So you're turning your head, you're twisting, you're bending, and every time the distance between the stimulating electrode and the dorsal column keep changing. So the patient sit down doing everything as a minimal paresthesia, happy, and all of a sudden you try to twist to pick up something or bend to pick up something from the ground. You get very closer to the spinal cord, the stimulating electrode closer to the spinal cord, patient zapped. And then he's jumping. And people, they have to take it out because they are driving. And when they turn their head to the blind spot and all of a sudden they got the shock, they disturb them in the driving, and then they cannot tolerate that. That's what's called open loop. The closed loop here, the battery or the brain start to communicate with the body and start recording the movement and calculate the distance. And based on the distance of how far you are from the spinal cord in a second, can it change the energy that can be delivered direct to that and prevent that shocking sensation. Senza came up, which is HFX or high frequency, came up with another one, and I got the pleasure to be the first implanter of the artificial intelligence IPG here in Houston area. Amazing. I mean, you have the phone, and basically what you do after you put the battery in, you communicate with the phone. I feel pain on the 5 o'clock p.m. and I'm okay in the morning, and whatever you're gonna tell, the apps communicate with the battery and start to do immediately change. So basically, instead of calling me or calling the rep to do some changes, basically you communicate with your app through your phone, and the phone will communicate with the battery or the IPG, and the IPG start to change the setting based on your personal requirement, not in general. Future, who knows what's going to happen tomorrow or after tomorrow. I think there is a couple of things related to that very high frequency to deliver this very high 50K shock or 500K shock to the spinal cord, do what we call action potential arrest for about 4 hours. The battery will shut down. And then after 4 or 5 hours, when you have the lingering period disappear, then you got to shock another one. All these things on the mind and the ideas, and we will see how the future looks like. I want to thank you so much for everyone. Thank you for time.